What's starting to happen is an understanding that there's multiple tools in the toolbox and how to reach for each one of them. What I am referring to is that if someone had nerve pain, let's say, for example, from a disc extrusion, and that material escaped from the disc, it's a jelly donut, and that jelly is incredibly caustic and abrasive and causes inflammation, causing what we term in layman's terms as sciatica. That nerve root pain can be treated in a number of different ways. When previously the suggestion was perhaps maybe I'll just give opioids, now the suggestion is can I refine which nerve root's involved? Is this nerve root, is it significant enough that it requires surgery? Maybe it doesn't. Would the patient benefit from a specific injection, actually interventional therapies guided by fluoroscopy to provide medication over the nerve root? Specifying sophisticated physical therapy to help patients. What's the role of acupuncture, for example, or touch therapy, massage therapy? Appropriate nutrition. Does that play a role? What's inflammatory and what isn't when it comes to what we put in our body to consume, to eat? These are all questions that are starting to kind of gel to formulate very comprehensive, effective treatment plans that are really constructed by multidisciplinary teams, which is what we do here at UC Davis. And that's kind of the suggestion from Washington, is like, what do we have in place? I think when it comes to understanding the real crux of the issue with regard to pain, the importance on education was key. So it wasn't just so much our workforce, it was the fact that there was a gap in education at the medical school and even primary education curricula when it comes to healthcare. So there's a thrust to actually improve and design curricula that are reflective of this important need of understanding pain management. I think that there's resources that are different in every location, and certainly as we look at this from a global perspective, there are areas that are resource limited. If we're looking at developing countries that have established aspects of their healthcare system to tackle this, I think it's very much the same. The low cost but high yield benefit of appropriate education to make providers aware of all the opportunities available for patients in pain is certainly one of the major tasks that UC Davis endeavors upon, my colleague Scott Fishman and many others, and that's going to be addressed at the next International Association for the Study of Pain. I think that we're at the cusp of really putting our thumb on understanding the major problem, which being education being one of them, and then trying to address it by changing curricula. I think for many years, the god Morpheus and the solar system revolved around the opioid concern. However, what we've learned, like for example, that I gave you of sciatica or nerve pain, if we're able to determine which nerve is the problem, we're able to actually use medications in an interesting way. For example, nerve pain in and of itself, neuropathic analgesics, which are some groups of medications like gabapentin or Neurontin, other what we would call nerve membrane stabilizers or anti-seizure medications, can be used to treat nerve pain. Also, antidepressant specific types.